Welcome, everyone. It's really super to see everybody joining us for our monthly webinar on OHTs. And I see we have lots of people signing in today. We are already at 200 people signing in, so please let us know who you are by introducing yourself with your name and your OHT or other organization in the chat box. When you click into the chat box, please make sure that you click to all panelists and attendees in the chat when you introduce yourself. Welcome. So thank you. Hi, Emily from Brampton, Tim, Marjorie Conan from East Toronto, Rebecca from Rehab Care Alliance. Good to see everybody joining in. Emily Lamb, East York Region, Bernard Leduc, Karen Armstrong, welcome. Tina from Alzheimer's, welcome. Welcome, Kim from Hamilton. Welcome to Nasir. They're coming fast and furious now. Joanna from Burlington. Ruth from Ontario Health in Toronto. Welcome. It's great to see everybody signing in. Joanne Cormack. Gabrielle from the Rehab Alliance. Dave Jeffrey from Midland. Edward from the Midwest Toronto. Welcome. Nadine from GP from Orleans. Welcome. Welcome to Monique Rocheleux. We have many, many people signing in. We're passing 300 people now. It is highly likely we are going to get very close to our max today. We are slightly oversubscribed, so we'll see how it goes. Please join in, introduce yourself by your name and your OHT or other organization in the chat. Let's welcome everybody. Many people who are joining us from all over Ontario today to hear about, and really not just to hear about, but to share in our community and to participate. We are really just here to empower you and to enable discussion amongst yourselves and with us in collaboration. So welcome. I want to start off our work. Everybody here is from many parts of Ontario and possibly even further abroad. I am speaking to you today from the University of Toronto. I just wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. It is now home to many diverse First Nations, Inuit, and Métis people. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. We acknowledge that Canada is home to many diverse First Nations, Inuit, and Métis peoples, and that many of you are joining us from one of those many traditional and treaty territories. Acknowledge and thank you. We want to start off today, as people are still joining in. We are at about 400 with us now. We're going to start off right off the top with whether this is the first time you have joined us. We know that some people out there, so you can just click in your answer. And here we go. You can see that we have 167, 47% have joined us previously, and we have 188 new people, 53% joining us for the first time. I always find this amazing that we have so many people returning, but we also have many, many people coming back in. Thanks for joining us today. Today's event, we're going to talk to you about our evaluation plans and some of our indicators. I will host and talk about some of the aspects, but today we have excellent people that are working to support the evaluation and performance measurement across Ontario, starting with Dr. Carrie Koleski, the Matthias Giesler Research Chair in Patient and Family-Centered Care at Trillium Health Partners, Dr. Ruth Hall, co-lead for the Ontario Health Team Evaluation with our team, and Jillian Paul, who's Director in Integrated Policy and Planning in the OHT Division at the Ministry of Health. And Jillian will talk to us about some of the ministry's plans for performance measurement and the alignment with the work that we're doing. So welcome to all of our speakers, and you'll hear from all of us today. We have an active meeting today. We're going to talk about two main points, one being the Quadruple Aim Framework and our approach to measurement for the OHT evaluation. The second part is around alignment with the Ministry of Health performance measurement, as well as some indications of individual OHT indicators. A little bit of feedback to the teams that Jillian will share around some of the themes and topics that have been raised by the OHTs in your indicators sent to the ministry for the TPAs. So we'll get to that a little later. It's going to be a very active session. We have with a lot of information shared, and we've been asked in the past, sometimes we have a lot of information, what are the key takeaways? Also, sometimes people sign off early. Today, we have key takeaways of measuring patient and provider experience using a common recommended measure, and we're going to talk about those, both patient and provider experience measures. We're going to recommend how you will be able to use system improvement measures and target population measures to identify opportunities for improvement in your OHTs. And this is the first year we'll be doing this. We have lots more to come ahead. We want to highlight that we have high alignment between the work that we're doing in the evaluation, as well as the Ministry of Health performance and your own improvement measures. And finally, an emphasis for you to track and report locally on what matters most to your team. We're going to support broadly what we can, uniformly across the 42 and more to come OHTs, but really we remind you that evaluation has to be local. So throughout today, we're hoping that you will take the opportunity to exchange your ideas with your fellow Ontarians and people involved in the OHT initiative. Ontario health teams have varied groups of providers, varied first-year populations, and we know across the many teams, varied resources, tools, and approaches, and we have to be cognizant of this. We aim to support all OHTs similarly, and knowing that evaluation has to be flexible and should be local. And so we're trying to provide help and support along the way to enable you to have strong local support for your OHT evaluation. We have some central activities that we've been doing, which we show here on the bottom. Formative evaluation using surveys and interviews. We have some reports from the first cohort that we gathered information on last year. And the second cohort are currently in the field from the second group of 15 OHT applicants. Today, we are mostly going to talk about this phase 2, provincial reporting. What is that going to look like? And how do we support patient and provider measurement across the OHTs? That will be the focus for today. Our framing of the evaluation metrics is around a quadruple aim framework, and this is adopted. The ministry has put this forward as a proposed approach. We strongly support this approach. We've used it in past evaluations, and we also note that many OHTs themselves have been promoting this approach around patient experience, health outcomes, provider experience, and cost. And we're going to talk through each of these today in separate parts. Starting up with patient experience, I am so pleased that Carrie Koleski, who's really helped put our focus together in this space, will be able to come now and talk to us and share some of her thinking that she has shared with us previously on how we developed patient experience measurement in OHTs. Carrie, please go ahead.
Great, thank you, Walter, and welcome everyone. It's great to see that we have, 477 participants. So you can advance to the next slide. So in understanding your populations and your OHTs and your patients and families, this quote by Albert Einstein really grounds me all the time when he said, not everything that counts can be counted, and not everything that can be counted counts. And so in the work that we've done in developing measurement tools and the work that you could do with your OHTs is really starting with the experiences of the patients and families within your OHT. So who are they and what matters most to them in their day-to-day care and in their lives? And so in the work that we've done together as a group, my main contribution has really been around finding out, what matters most to patients and caregivers in their care. Next slide. And so our team started with 172 in-depth interviews with patients and caregivers, focusing mostly on people that had multiple complex conditions and social care needs, and a family and friend caregivers of these types of patients. And we focused on folks in Ontario, Quebec, and New Zealand in this project. And we had about 8 different ethnic groups as as part of our sample, white Caucasian North American was actually the minority within our samples. We had a lot of ethnic diversity and lots of jurisdictions that we focused on. And we conducted in-depth interviews to really understand what's working well in your care, what's not working well, and what needs to be done to improve things. And as we combed through all 172 interviews with patients and caregivers, we did a thematic analysis and came up with these 6 core attributes that you see on your screen. And first and foremost, across the board, caregivers and patients and clients said they wanted to have at least one person in their circle that they could count on. If they had questions, if they needed supports, they needed access, it could be a peer, it could be a family member or a care provider. So having that one person to count on was absolutely critical. Another key attribute was to feel heard in their day-to-day care interactions. So that would be the provider or the team taking the time to really listen, to ask questions beyond healthcare. So the provider and the team learning about the person and their context, what they were most concerned about, and not feeling judged in that interaction. Another key attribute was really knowing how to manage health presently as well as into the future. So having really honest conversations about, for example, if the person had multiple chronic conditions, that maybe things would be uncertain for a while, but they would work together to figure out a plan and check in regularly to try to improve care. So having those honest interactions about, what the go forward plan might be. And those 3 attributes really enable, that 4th attribute of easily accessing health and social care that's meaningful. So that would mean if they have an appointment that they had the means to get there. For caregivers, it means support with out-of-pocket costs, for example. So, it's not just about what they get, it's about that service bringing them value. And ultimately, at the outside of the circle, you see those final 2 attributes about feeling independent and feeling safe. And being independent was about doing things that you value as a person. So being able to essentially live your best life. But also independence came out in that care interaction. So do they feel like they have a say in their care plan? Are they involved to the extent that they want to be involved? And then feeling safe. So feeling that they could go about their day, they felt safe mobilizing and moving around in their homes, outside of their homes, and for caregivers, feeling that their loved one was safe, particularly for people that were declining or had dementia. Family members were often trading off between helping their loved one feel independent and feeling safe. And so this created a foundational framework from us to then build and design survey tools. We then focused on home care populations. So we looked specifically at Ontario home care patients and caregivers and started to learn about their experiences and realized that it largely mapped onto this framework as well. And I'll point to, there's a practice guide that's located at the link that you see at the bottom of the screen, where you can get more information on what these attributes mean and how they can be put into action. So next slide. And so in addition to doing the foundational work of a number of one-to-one interviews, we also did focus groups. We also looked at the literature to see what other types of measures existed regarding patient and family experiences. And we really honed in on the home care literature, given that was the focus of the project. And then we started to map these measures and the attributes within the measures against those core categories and attributes that you saw on the previous slide. And then what we did is based on the literature review, we pulled out all the different ways to ask questions about client and caregiver experience. And we actually put those questions in front of clients and caregivers to say, do these make sense? What types of changes would you recommend? And how do we make these as clear as possible? So as we were engaging with clients and caregivers, we also asked them to give us feedback on these questions. And then eventually we designed the survey tool and then did extensive field testing and validity checks to ensure that the questions made sense, that they were providing meaningful responses. And then from there, it was really about how do you take those survey tools and make it generic and useful enough for an OHT population, which, as we know, is cross-sectoral, not just home care focused. And so we're in the midst of putting together a measurement tool that hits on all of those attributes, and many of the questions within the tool that we have to date really, captures a lot of the questions that we've tested with the client and caregiver population. So you can go to the next slide. And so just to give you a flavor of some of the survey items that we've added, and some come from pre-existing tools, but others we had to create because we found that they were missing. And, as I mentioned in the attributes, having someone to count on if needs arise was critical. So having a question that really hones in on that is important. But a secondary part of that is, does that person that's counted on, are they able to get what the person needs? So do they have access to a team or to resources to then respond to the person's request? So those two things really need to be tapped into. Also, being involved in decision-making to the extent that's preferred, because not everyone wants to have a partnership role in their care. So understanding how people want to be involved and the extent to which they want to be involved. Perceptions of how well care is organized, because we know people are getting care from multiple sectors, providers, services. Access to support for daily activities. So it's not just about getting healthcare services. It was about like day-to-day activities, instrumental supports, shopping, housekeeping, the things that people need to do to stay independent in their homes. And another piece that we have within the survey is access to health information to tap into. Do people have access to their records? Do they feel empowered and kind of understanding the information that is there about them and their care? And those are just some examples. And of course, having an open-ended question is really critical too, because going back to my initial quote, it's important to kind of unpack that context and see if there's, to capture other things that might be missing from the survey tool itself. Next slide. And then, of course, really important to capture the personal characteristics and social determinants of health. So tapping into gender identity, race, the extent to which someone feels isolated. Do they experience vulnerability with housing, with income, with food? So what are those social care needs of the population that you're working with? Next slide. And, a lot of what I've shared is as it kind of pertains to the patient and the client experience, which is where we focused so far. So I wonder, if we were to develop a caregiver survey, would that be something that you're interested in? So we've just launched our second poll. How likely is it that you would use a caregiver survey if one was made available? Because we often focus and default to focusing on the client and then might not, focus on the context and supports around them as much.
Okay, so we have about a quarter of people being certain to use if there's one made available, very likely about 42%, about 34% in the might or not likely. I know that when we have tried in the past, sometimes reaching out to caregivers can be a challenge when you're trying to do things like surveys. But thanks to everyone for including that information, and on we go.
Another consideration with measurement is, we're sort of hyper-focused on the healthcare experience, which is critical. But what about the health experience? Because, as we've learned and as we know, much of what matters to people really lies outside of healthcare, but it directly impacts on their health outcomes. So for example, being independent, being socially connected, living a life that brings value, feeling like you're part of a community, all of those things are absolutely critical. And if not addressed in an upstream way, they'll trickle down to poor health outcomes, healthcare utilization. So we have to think about what is our responsibility of tapping into those components in addition to the healthcare experience components. Next slide. And this is, I think, the most important piece is what you will do with the information you collect. And so we often hear from clients, patients, and care partners is, I keep telling my story over and over and over again, and I'm never clear what the result is of what I'm sharing. And so this home care client said to us, the only reason I would fill out a survey is I would hope that there's a group of people, including patients and caregivers, that are looking at the data to improve the gaps. So with any measurement strategy that you do, it's important to think about, okay, so when we get the information trickling in, how are we going to respond to it? And then how will we loop back with our community to tell them, this is what we heard and this is what we've done. And we can do this, but we can't do that because. So it's about closing that loop and working together on how you can use the information you're collecting, and probably considering that the survey component is one of many mechanisms to get information on your population. Because as we know, surveys don't really capture the context. So you'll want to tap into those contextual pieces in other ways.
Great.
What?
Yeah, thanks, Carrie. I'm just going to come off a little bit now, and maybe Carrie, I think the chat's been quite alive with some comments from the audience, and I think there might be a few. Jen, are there any poignant ones? And we'll encourage you, we very much strongly encourage everyone to continue to use the chat to all panelists and attendees so that you can continue to discuss. We'll just be the background music.
Yes, so the chat has been very lively so far, and we have a couple of really great questions that I can pull up. So Rod Burns asks, given the support and need, can equity be considered a fifth lens of the quadruple aim? OHTs are also trying to reach disadvantaged communities and need to check in on their efforts in this regard.
Why don't we take that one up at the very end of our session today, because I think we're going to speak about it. Carrie did talk about equity a little bit through some of the dimensions, and we're going to touch on it in every aspect today. So we'll bring it back at the end. Jen, can you make sure we do?
Perfect. I'll keep that one flagged. We have 3 more questions that were picked up. So Riham Abdelhalim asks, thanks so much for touching on the being safe point. I wonder, was there any participants in your interviews who noted safety beyond being physically safe to cultural and social safety?
Yeah, thank you, Riham. That's an excellent question. And I think the cultural safety piece comes in how people feel when they're interacting with their care teams and their providers. And so it's about feeling that, you know, they're in an environment where they can truly open up, not feel judged, and feel understood within their context, and feel that their background and their story and their history is respected. And so for people that had been working with a provider or a care team over a period of time, started to develop stronger relationships with their teams, with their providers, where they felt like there's kind of this unspoken kind of connection that they felt. And I think that gets into the importance of continuity of care, but also patients and caregivers talked about when the provider came from a similar cultural background, a similar ethnicity or race. And we heard this in the Maori population in New Zealand in particular. There are certain cultural customs, behaviors, and the way people interact as being culturally accepted that created a natural comfort between people in their care interactions that could happen from the get-go because they had that similarity in experience. So I think that's where the equity piece comes in too, is who's your population? What kind of context and interaction will help them feel most comfortable in telling their story and feeling connected? And this is where the importance of peers might come in. So having a peer on your team who can culturally connect on that kind of level of having a similar background and shared understanding and shared values.
Perfect. Let's take one more, Jen.
Mm-hmm. And I see a few more questions are coming in. So I think just to let these people know, I see questions from Ivan Ip, Dina Franchi, and Vimal Kurian. I think we'll save those for the end, just in the interest of time, but to note these have been captured. The last question that is here is from Emily Lamb. She asks, are there existing validated caregiver surveys? I'm familiar with one for palliative care, the Caregiver Voice Survey. It's been used in the past in the Central LHIN.
So in the literature review, not a lot of comprehensive caregiver surveys came up that had been validated. What we tend to see is a lot of really focused measures. So there's tons of measures on caregiver stress, for example. So you'll find that there's a lot of tools that tap into one piece, but finding something that is comprehensive, that's going to cover, you know, caregiver stress, access to information, do they feel supported, do they feel safe, do they feel that their loved one is getting what they need? I would say look to the UK as well, that automatically now assesses the caregiving population. And it's almost like equivalent to a RAI assessment tool where it's quite comprehensive in terms of the types of questions that are asked, but also with the purpose of linking the caregiver to different services. But I would say that that's a gap that we need to fill. And I'll check into that palliative care survey that you mentioned. Thank you.
Yeah, voices has been used a lot in Ontario, particularly because often with people near the end of life, we don't want to ask them questions. So we really rely on the caregivers, and that's a tool for that. We're going to go on now. Carrie, you might also be able to look at the chat and see if there are some that you can respond to now that we're going to have Ruth talking to us a little bit about our work in measuring provider experience. So I'll turn it over to you, Ruth. Do we still have Ruth? Coming off mute. Okay, we're going to troubleshoot that one in the background, and I'm going to talk through this a little bit until Ruth gets off mute. Ruth has really led this work, and we want to make sure that
I'm off mute.
Ah, thank you. There we go.
Oh, my mouse, I think my battery must be dying on my mouse. Sorry about that. Thanks, Walter. So this has been a team effort for sure for HSPN. We recognize that this was an important quadrant for the quadruple aim. And so we undertook a non-systematic rapid review of the literature for existing provider tools to create an inventory of items to develop our survey. Key to our review was the focus on measures of the experience from the provider's perspective, opposed to engagement, which tends to bring the organization's perspective. We also took into consideration the OHT context, meaning that we need to have multidisciplinary teams that have coordinated or integrated care. And so the constructs that came out of this rapid review are things like burnout, workplace culture, autonomy, satisfaction from the job-oriented experience of satisfaction, and the alignment of the job with their personal values. So we felt that the RAND survey really did have many of these key constructs that emerged from our review. And we focused from that RAND physician survey on satisfaction, stress, burnout, practice setting culture, and autonomy, feeling valued and respected, as well as some EMR specific elements as well. Again, we also looked at GITLs, related relational coordination, as this again speaks to the OHT context. And we also used our OHT leadership survey, looking at the items in the area of team climate, commitment to improvement, and functional integration. So the 5 domains we came up with were the burnout, workplace culture, autonomy, satisfaction with the job-oriented dimension of the experience, as well as feeling valued. So we took these items from these various surveys and that gave us about 90. And then on our team, we did a modified Delphi to come down to 39. So we got these 39 items and we put them into the domains and then approached 6 focus groups. And we had family physicians, we had a focus group for specialists, as well as nurses, allied health professionals like physiotherapists, occupational therapists, dietitians, social workers as well, and mental health and community workers, and then PSWs. So we had a wide variety of providers, and that's what the intent was, is that this survey needs to address all types of providers. But we began the focus group with an open-ended discussion of what the participants felt was important to them, and how they thought their roles might be impacted with the OHTs. And then we discussed the survey items, as our tentative guide to just get a gauge in how they resonated in measuring and capturing experience from their perspective. And we refined our survey items after each of those focus groups based on the feedback we obtained. And then finally, we undertook some cognitive testing to understand how the respondents interpret the questions and the instructions, the layout and the flow, and also the timing. Next slide, Walter, please. So our final survey does capture 5 domains, as I mentioned. We just have the headings slightly altered from what we found from our rapid review. And that is the domain of focusing on care coordination experience. What is that like to coordinate the care across the various providers? What's the workplace culture like on the team, the OHT team? What's your sense of autonomy and control over your work, your day-to-day work? And then digital and virtual care, getting at EMRs and virtual visits, et cetera. And then we combined burnout and satisfaction together. And we have 39 questions. It took for sure 15 minutes, less than 15 minutes actually. And that included also completing demographics and some general sense of the types of patient groups that or client groups that the various providers care for. Next slide. So just some examples for you of some items that we have on the survey. Each of the items, or most of the items, are based on a 5-point Likert scale, and things like patient care is well coordinated with community resources. How much do you agree with that? And how much do you agree it's possible to provide high quality care to all of your patients or clients? And do you feel that leadership provides or promotes an environment that makes the work I do enjoyable? And also asks that about, does it provide an environment that makes you feel safe? And I enjoy my work and I have no symptoms of burnout. So that's just a sampling of some of the 39 items on that. On to another poll to get your feedback.
Great, thanks. And so here we're asking people, if you think about in your OHTs, how easy would it be for you to identify the providers that you think would be important to poll with this kind of a survey? And how would you be able to identify the right people and be able to share and distribute it out? Lots of people coming in, high levels of participation on this. So here we go. And sharing the results out, you see that I'm surprised actually that 53% should be easy to distribute to providers. I would have thought it would have been a little lower than that. This is encouraging. It'll be moderately difficult and we'll have to work to support that work. And then it may be quite difficult. Only 5% think that. So that's somewhat inspiring to us, I think, Ruth, as we think about our ability to launch this and support OHTs with this work. We're going to move on to health outcomes. I think it's still you.
Yes. Yes. So the next quadrant being our health outcomes, better patient and population health. Next slide. So health outcomes are really critical to measure, of course, and we want to do this through the Euro Quality of Life 5D 5L survey. That captures mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. And we are considering putting this into the patient survey to get patient-reported outcome measures. We're also going to report on population health, and the metric we have identified to be relevant to this is the premature mortality rate across the attributed population. That is for those people, the death rate for under 75 years of age. And of course, we'll also have our proxy measures of health outcomes, for example, our unplanned hospital hospitalizations. Next slide. So how did we come about selecting the proxy measures of health for our OHT attributable populations? Of course, we started with our literature search and scanned many of the Health Quality Ontario Health System reports, as well as our Health System Performance Network evaluation, and came up with 18 measures. And 7 of those 18 were included in the full applications. And in selecting the indicators, we had the criteria that the data must be from administrative database so that we can have this measured across all the OHTs. And then we decided with a modified Delphi procedure and our team that we would select 8. Again, we want to have a digestible number of indicators. And in terms of validating those 8, we felt we did a pretty good job. 7 were included of those 8 in the OHT applications, and 6 of them are included in the ministry's data package on that performance indicator tab that all of you would have received. So we felt we're not bringing up anything new, and we can't have any more new indicators. Next slide. So our 8 indicators that we would like to report across all the OHTs in looking at outcomes and a proxy experience access as well is, first of all, there are avoidable emergency visits for conditions that could be treated in a primary care setting per 1,000 population for those 1 to 74 years of age, CTAS 4 or 5. These indicators are going to be reported at using the ministry's resource indicator standards. So you're very familiar with this indicator, I'm sure. We also will report on total hospital days across the OHTs for the 42 OHTs, and ambulatory care sensitive care hospitalizations per 100,000 for those under 75. And again, this is also your from the MOH resource indicator standards. 30-day readmission to acute following discharge from those HIG conditions from the HBAM inpatient group. Again, you're very familiar with this indicator as well. A new one will be that maybe you are or are not familiar with is the continuity of physician care. And that's defined as the proportion of consultations that are conducted by the physician consulted most frequently in the past year with a minimum of 2 visits. And that those visits happen within office settings or long-term care settings. Virtual physician encounters is new, although many of you have put that on your OHT applications, and this will be over the last 12 months. And 7-day primary care follow-up visit from a hospital discharge for the conditions that you again are familiar with, AMI, CHFs, COPD, pneumonia. Again, it's the MOH resource indicator standards is the method of calculation. And finally, it's wait time to home care from a community-based referral. Next slide. And health equity is central to our reporting, and the patient experience measures will be analyzed and reported by the social determinants of health, as Carrie mentioned. And our system measures will be analyzed and reported using age and sex adjustment and risk adjustment where appropriate, again, using the standards that you're familiar with from the ministry. And we will also report on the ratio of highest to lowest quintile on the neighborhood material deprivation index. And that is a census-derived measure at the neighborhood level, looking at things like the proportion of families who are lone parents in that particular census tract, the proportion of those age 25 and older that only have a high school diploma, the proportion that are receiving government transfer payments, the proportion of the population in your neighborhood that's over 15 that are unemployed, and the proportion that are considered low income, and households living in dwellings that are in need of major repair. So it's a constellation of different things that are measured in the census, and it's will be used to create an index, and then we will report the ratio of the highest to lowest as well to support this equity lens, which is very important to identify where there is greater need and needs for improvement. Thank you.
Yeah, thanks a lot, Ruth, for leading us through both the provider and also our area of health outcomes. I just want to pause here, come off. I think that slide talked about the equity, which was raised earlier on, and we are. Our view is that we need to think about measuring equity at each step along the way. And you could think about that as a fifth dimension, but for us, it is not something that we'll measure in and of itself. It is the way we measure patient experience. It is one of the aspects and lenses that we'll put on provider experience. It is the way we'll look at all of our health outcome measures across the system in whatever way we can. We have various ways to ask about equity. I saw a comment in the chat near the end about race-based data. So we will be able to collect that prospectively. And as groups come online, more so, with having more race-based data in admin data, we can in the future do that. At present, we're quite limited. We can look at ethnic concentration, but I think the first most important dimension is probably just the inequity in health outcomes as we look at areas and neighborhoods of deprivation. That has been one of the strongest. We have a couple lenses we can put on this. But that will be the first way. So just in terms of our thinking around equity is that it is in everything that we do. We will also look through an equity lens. I want to come back to one question that I saw in the chat, and then Jen, you might raise a few others just before we go on. That, you know, I did see the notion around thinking about where the sources of data are coming from in terms of ensuring the validation of these tools. Very good point. And we can actually, in some of the measures, do that from past data that we've collected, but future-oriented, as we look at the tool's validity, a couple of things. One is we need to do it in the people who actually receive care from your OHT. As of yet, many places have yet to deliver care through the OHT model, and as we start to see that, we will be out doing further validation within those populations, and I think that's really important for us. We're at the point where OHTs are just in their launching point, and so this is where we'll start. But as we've said in every webinar along the way, if we're measuring the same thing a year from now, then we probably haven't accomplished much. And so we do need to be thinking about how do we adapt and change, and we won't be stuck in this. This is where we start, and you are starting in places, and we all evolve together. I just want to make those comments, and then Jen, I don't know if we have I'll just take maybe one or two questions now, and then we'll go on.
So just to acknowledge the questions, the themes that seem to be running are very much on this equity-focused issue and also adaptations in light of COVID. So since we've talked quite a bit already about the equity piece, I'm saving those questions for later, and I will bring up one of the questions about the COVID implications. Actually, maybe I'll ask two. The first one is from Linda Wakelin, who asks, how do you interpret provider experience results in light of unusual events, such as the pandemic, which could skew results at a particular time? And then I will also add on, because I think it fits, Dave Pearson asks, perhaps a loaded question, but how has the urgency or impact of the ongoing pandemic shaped the measures for OHT performance?
Those are both very excellent questions. We cannot escape COVID-19 in any way, shape, or form, and it definitely will appear in all of our measurement. And we are measuring and operating and living in the context of COVID. And as long as that continues, we will measure and report in the context of COVID. And if we get past COVID, then we will measure and report in the position of being past COVID. And that is the reality of where we are. We cannot possibly disentangle what's happening as a result of COVID compared to what's happening as a result of the OHTs. However, if we are looking in a number of these measures to people who are implementing OHTs versus people who are not yet implementing OHTs in the context of COVID, that comparison may allow us, and changes that may be differential between those two groups might allow us to disentangle a little bit of that non-COVID OHT effect as everybody's experiencing COVID. To different extents, I will absolutely acknowledge it is to different extents, and we need to think about how do we deal with that. So I just want to make sure we'll have time near the end to catch up on extra pieces, and I want to make sure that we do have time for everyone's material coming in here. I'm going to come back to our slides, and the last piece, and Nashaba Degani said, I don't see anything about mental health and addictions. I'm going to answer your question, Nashaba. Okay, so we also, that's our core. What we've talked about is our core work on performance metrics across all OHTs that'll be relevant, we think, to all OHTs. We did very much understand and pay attention to the fact that there are a number of year one, now maybe talking more about focal populations that were frail, complex older adults, mental health and addictions, and palliative. We also see a few others. The dementia, I think, may fit somewhat in either older adults, is probably where it will come up mostly. And then we have various chronic diseases. We picked the top three here and said, let's think about measures in each of these top three populations that may be relevant across both OHTs that have focused here and also OHTs that have yet to focus here. And I explicitly and very consciously use the term have yet to focus here because I do think that everyone is going to land here soon enough. So in these areas, we also did a scan of current reporting in Ontario, so quality of care reports in Ontario, specific for mental health and addictions in this case. Plus we looked at measures that were being promoted and within OHT applications. So, ICES has the mental health report, and we also had the OHT applications. We came up with a list here of 32 possible applications, possible indicators, 8 being from the full applications. Then we looked to say, what can we measure readily in our administrative databases across all 42 OHTs? And we worked through our own team. We had 5 of us going through a modified Delphi to select 6 indicators from 32. And then we went, what is the most relevant external body in this topic area in Ontario? And we went to the Mental Health and Addictions Center of Excellence jointly through CAMH and Ontario Health. And from there, we ended up with a selection of 5 indicators. Here are our indicators for mental health. First contact for mental health is in an ER. So we hope to catch people a little bit earlier than that in community settings. Did you have 4 or more ER visits for a mental health condition? Were there ER visits for self-harm? Did you have a 7-day post-acute physician follow-up after a mental health admission? And did you have to return to the ER after a mental health admission within 30 days? So those are the 5. These are very short lists because we have 3 populations. For older adults, we also did a similar scan. The Canadian Frailty Network had done work, ICES had done work, Rehab Care Alliance. And so we came up here with a list of 37, again, put it through the screen of administrative database and our modified Delphi internally with our measurement experts. And then we went to the Ontario Provincial Geriatrics Leadership Office and asked for their advice. And we have 5 indicators that were endorsed most commonly through that group. And here they are. The first one is an administrative measure we can calculate for the entire population of all older adults, and that would be 2 or more fall-related ER visits. This group, and we strongly support this work, these are our proxy measures for health outcomes. So how can we, as much as possible, in as wide a population as possible, actually measure health outcomes? We have in Ontario extensive use of the RAI instrument, and it has limitations, but it also has pretty good coverage, and it's probably one of the most widely used measures where we can capture health outcomes. So we have RAI-based measures for health-related quality of life, physical function, cognition, and also admittedly a weak, but there is a measure of caregiver distress out of the RIE tool that we will capture as one measure that we can map out at a provincial level at scale in all OHTs. We will be using RIE-based measures from home and community care. We'll also be looking at separate reporting possibly for long-term care settings, but primarily our focus will be on home and community care in the community in our first pass. For end of life, again, actually in this case, our network, the Health System Performance Network, has done quite a bit of work in the area of palliative care measurement, led by Peter Tennis-Putro and colleagues out of Ottawa. And you can see many of our past work in this area. Again, passing through the administrative database in our own Delphi. And then we went to the Ontario Palliative Care Network, and we selected 5 indicators endorsed by that group. And here are our end of life measures. We would like in the future to move closer to palliative, but for now it would be end of life, place of death, having a home physician visit in the last 30 days alive, the number of days at home in the last year, half year, ED visit rates in the last 30 days, and the % with palliative care in the last 90 days of life. Not perfect, but the best that we can do at the moment. So there's our view of how do we get at those individual population metrics at the outset as a baseline. The other piece that we plan to report out on are some contextual features across the OHTs, all according to the attributable population. So some socio-demographics, morbidity, emergency visit rates, like just overall, so that we can put into context. A number of our measures are related to ER. So how did these specific measures compare to the general rates? Hospitalizations, and then again, similar for mental health and addictions, those individuals. And then we're going to explore more work in this space of identifying frail. We will be starting with people over the age of 66 and above, and that's so that we can measure out things like dementia, which require that we have Ontario Drug Benefit ODB data in the administrative databases. We have a number of ways of thinking about frailty that we will explore over the course of our work. For now, at the outset, we'll have some basic contextual demographics. And our last quadrant to cover off is cost. Well, very simply, and we've done a lot of work in measuring cost across the province, and we can measure at the individual level everybody's total system cost per person per month in the attributable cost, attributable populations for each OHT, and that will be our metric. It will lag a little further some of the others as we wait for cost data to come in, but we will be as current as possible in our total system cost so that we can continue to measure and monitor this as well. Our work will be reporting back out to OHTs on these indicators overall and for the target populations. We'll be reporting out 4 years of data from 2016 to 2020 in this spring. And then we'll continue to report over the coming year with the cadence for these indicators to be determined based primarily on how much they're shifting or changing over time. If they're quite stable, we may report less often. If we see changes, we'll report more often. We will provide support for patient experience and health surveys from starting in April. We will make available online hard copies that you can use yourselves locally. We also intend to make available an online tool that you can use to distribute electronic surveys to patients, and also for our provider survey, the same piece. And so that these can be made available broadly. If you're using our electronic tool, we'll send back to you the data that people have submitted through our data collection tool so that you may use it for your own purposes. We don't have capability of having data sharing agreements for direct distribution of these tools across 42 OHTs in the next 8 months or so. So we're going to do our best to support your implementation of this work. And that's what this highlights. So we will have undertaking and reporting in the area of health outcomes and cost, and we will support your work in undertaking patient and provider experience. So hopefully this is going to be helpful to all of you. I have a last poll on our work, and then we're going to move on to Jillian to hear from Jillian. And so here we have a question about when you expect to see change happen. So tell me, when do you expect to see any changes in measures from implementing your OHT activities? Like more than 6 months, within 3 to 6, within the next 1 to 3, you're already seeing changes, or it really depends on COVID. Here we go. We're not ready yet, say a third. It'll be a while, but quite optimistically, almost about a third say within 3 to 6, or even within 1 to 3. And a few think they have already seen the impact of their OHTs. So congratulations to you. And then it really depends. I think that is going to be a piece that we're all going to have to continue to pay attention to throughout this space. Thank you very much for this part. And we're going to move on now to our great esteemed guest, Jillian Paul from the Ministry of Health. Welcome, Jillian.
Thank
the
you.
floor is yours.
Thanks so much, Walter, and thanks for the opportunity to speak today to this very large audience. Walter and I have been discussing for a while the OHT evaluation metrics, as well as what you'll see today, which is a little bit of an overview of the Ministry's OHT performance measurement framework. And we thought with this webinar being focused on the evaluation metrics, it was a good opportunity for us to provide a bit of an overview of the performance measurement framework. And hopefully this is not going to be, a surprise, and you've heard about many of the aspects within this framework, but I will say I'm just providing a quick overview, and there will be another webinar coming up shortly to provide a fulsome walkthrough of the performance measurement framework, to hear your insights on it, to get feedback, and to sort of pave the road ahead, if you will. So next slide, please. Great, thank you. So we've, Walter's talked a lot, everyone here has talked a lot today about the quadruple aim. And as we know, the goal of OHTs is that they will be in place in every region of the province, providing care to all Ontarians. And as was provided in the guidance document that that OHTs, the OHT vision is really based on, there are certain goals within it. One of them being that information will be accessible by the public on how their local system is performing, and that all OHTs will be held accountable for performance that relies on the quadruple aim. So I won't go through that because we've done a lot of talking about what the quadruple aim is, and you're all very familiar. But just to say that the OHT performance measurement framework is meant to really illustrate the impact of OHTs in the near term, and then over time assess the extent to which OHTs provide more integrated, coordinated care according to the principles of the quadruple aim. So next slide. I think hopefully all of you on the call today are familiar with the announcement that was made by the minister in December, that all approved OHTs will be able to receive implementation funding through a transfer payment agreement. The expectations for the use of this funding have been articulated within that transfer payment agreement, as well as on I believe at least one webinar or webcast, if not more. And really the expectations in the transfer payment agreement were drawn from and aligned with the expectations that were provided in the previous guidance document, as you'll see a picture of that on this page, and hopefully you've seen the link for that. And these expectations were also informed by consultations with OHTs. As we know, this is the Ontario Health Team model is really a kind of grassroots model, and is built by local providers. It's also, we're also informed by provider associations, other stakeholders, as well as many international external experts. Just to say, because we're saying it everywhere we can these days, that The ministry does recognize that that an iterative approach to really everything at the moment is important, and we do need to stay flexible with our approach. So we are very conscious, obviously, of the stresses, the strains on the healthcare system, and as much as obviously putting together and going forward with the performance measurement approaches is important, we are very conscious of really putting any more amount of work on the healthcare system right now. So we're trying to be, and we're ensuring that we will be as flexible as possible with our approach. So this slide is, in essence, a high-level overview of the OHT performance measurement framework. The framework does consist of sort of 4 big buckets that I'll walk through. But as I mentioned, I really want to focus in specifically on one aspect of it today, and there will be a webinar coming up shortly to talk through at a higher level, more detailed level, all of the aspects of the framework. But there are 4 kind of core components, with each component informing the others. And as much as this looks like, stepwise, I think, we're working on each of these pieces simultaneously. Internal and external consultations have been underway since the summer to validate and inform the components of the performance framework. And I will talk a little bit about early feedback that we've received based on these consultations. But one thing I wanted to note that isn't on this slide is that the sort of foundational element of the our performance measurement framework, of this performance measurement framework, is really around data and access to data and data literacy. So all approved teams, as well as in development teams, will have received data packages based on their attributed population. And in those data packages is information on a huge number of performance indicators, as well as expenses information. And that really does, I think, provide the foundation for teams to get an understanding of what their populations are looking like, and begin to sort of obviously inform conversations about what is important for each team, and can also lead to good conversations about what improvements are necessary and what successes could begin to look like. So data packages are in the hands of all teams. Newly approved teams will receive their data packages shortly, and we are working on data package 2.0 to go out to teams with some revisions to how the data appears, and some improvements to additional information that you'll receive. So again, today I just wanted to talk a little bit and provide a little bit of an update on OHT specific implementation indicators. So perhaps I'll just move on to the next slide because it provides a little bit more information. Thanks so much. As part of the OHT full application process, teams were asked to select performance indicators to assess their early improvement efforts. And these were self-selected. And we, over the past couple of months, have gone back to all teams to ask them to confirm which 3 indicators they'd like to choose, appreciating that applications were put in, perhaps a year and a half ago for some teams, and appreciating also that that based on sort of more information, a better look into data packages, teams may have chosen to focus on different improvement efforts. And we did actually hear back from, I think the majority of teams did refine their indicators based on what they'd put in their applications originally. And so I'm just going to provide you with a little bit of an understanding that that's what this slide does, is talk a little bit about that. But I just wanted to note also that indicators selected by OHTs will not be used for public reporting, and are rather to be used really to monitor OHT implementation progress. And the reason why the 3 indicators weren't selected by Walter or Ruth or myself is really because this is about your own team's success and improvement efforts based on, an in-depth look at what your data looks like, what your team is focused on, who your partners are, the conversations that you're having around your OHT virtual table. Just also to note that we are working really closely with HSPN to align evaluation efforts, evaluation activities with the near-term approaches to performance measurement. So getting into the indicators a little bit, OHT's self-identified 98 indicators, which were categorized into themes aligned with the domains of the Quadruple Aim, as you'll see on the slide. Common areas of focus in the indicators selected by teams included, the most efficiency and access, which, I think there are a lot of good integration measures that sit in those domains. Patient experiences and implementation of digital and virtual care, as well as COVID-19 response efforts. And this isn't something that we were surprised by, but it was apparent that many teams are sort of, using sort of IPAC measures, population health outcome type indicators, as we're in a state right now, obviously, where the focus on COVID-19 is something that they want to be measuring as a team. And we did hear, and we have been hearing in conversations with teams that the relationships that they've developed as being part of an OHT have really helped with COVID response efforts. And so we aren't sort of surprised to see that those are the indicators that are being chosen at this time. I think to the kind of question and conversation and answer provided by Walter, I think we'll have to assess sort of what that means going forward. And but obviously, the success of improvement efforts related to COVID response are successes that will be seen by teams. So it's interesting to see that we've received in teams that have chosen indicators related to that. So next slide, please. So I mentioned that we have been doing a broad scale consultation on the broader performance measurement framework, and each of the aspects of the framework we've been asking for feedback on. You'll see here just at a high level some of the feedback that we've received to date. So, on all components, I think it's been highlighted to us the need to ensure some standardization across measurement activities to promote comparability and consistency across teams. So a specific example of this is that, when we've asked teams to provide us with the 3 indicators for their teams specifically, we have seen a lot of consistency on what indicators teams are choosing, but maybe not as much in terms of the way that is being reported. And so what we're going to be going back to some teams with is a suggestion of measuring it in a standardized way according to standardized data capture that has already been clearly published, for instance. So as much as we want to make sure that teams are choosing indicators that are related to their own performance efforts or improvement efforts, I think it may in fact help teams to understand how teams are how other teams are reporting and to report it that same way. And then I'm not going to get into the next 3 because they are about pieces of the performance measurement framework that I haven't talked about today. And I know that we're wanting to keep to time, and Walter's done such a good job at keeping to time so far. But just to say that our next steps is that we will be, as I mentioned, contacting teams to confirm measurement approaches and indicator definitions to the indicators that have been self-identified within the TPAs. We're also planning a webinar, as I mentioned, so to stay tuned for the dates for that. And we're collaboratively working with the agency, with Ontario Health, to develop guidance for collaborative quality improvement plans. So you'll hear much more about that in the coming months and at the upcoming webinar. Thanks so much.
Super. Thanks so much, Jillian. And now we're going to lose all of our audience. Maybe people will stick around for a couple of this discussion and questions, even after having heard your your insights from the ministry, because I do know that it drives a lot of the work that people pay attention to. So we'd like to open it up. We're going to take a little break, and we have at least 10 minutes now to get some questions from you. Use the chat to reflect on your thoughts about how do you think we should be measuring OHT implementation and OHT success? What do you think success looks like or should look like in OHTs? And how would we know if we're progressing? These are the things that keep my mind working all of the time. But you have many, many insights out there. All of the panelists are going to be available for questions. So I probed those two things. What does success look like? How do we know if we're progressing? And I am going to come off so we can have a minute to chat and around with our questions, and I'll be able to bring up the chat so I can see it a little bit now. So again, please use the chat to all panelists and all attendees. I don't know, Jen, maybe we'll just pick up one or two. I will just compliment Jillian on saying that really a focus on data. Data are the foundation for a learning health system. And as we implement OHTs, we are really looking to build a strong learning health system at a macro level across the province, but in each OHT will have to be its own learning health system. And that really starts with data. And I say data to action, action to data, and really empowering it and driving it. So this, we talked a lot about indicators today, and we're really hoping this will be helpful to advance your work. Okay, Jen, do you have any questions for us? And I'll watch the chat a little bit too, but you already have been. Great.
Perfect. So while all these comments and questions come in response to the discussion question, just to even things out, I'll present one question from Jillian's talk and one question from Walter's talk. So Reham Abdel Halim asks, for Jillian's presentation, will the ministry be providing support to OHTs in terms of training on how to select and collect performance measures? I am thinking about the performance measurement models in BC, Saskatchewan, and Newfoundland, where primary care networks receive support in terms of training or expert personnel who help implement and operationalize performance measures recommended by scientists, research groups, evaluators, and the ministry.
So, I mean, I think that there's a lot of meat in that question. You know, I think so as we move forward to the development for asking teams to develop a collaborative quality improvement plan, I think, you know, we know there are certain sectors in health that have been doing this, that have been mandated to do organization-led QIPs for quite some time, but we also obviously know of others that haven't been involved in this, and you're specifically talking about providers of care, so primary care providers, and I think, you know, it's not something that we haven't heard already in terms of, you know, how do we ensure that the participation of providers and that they're at the table and that they're providing feedback to the improvement efforts of their teams. And I think we talk a lot to the provider associations, and I think that this is on their radar as well, and in how we engage providers in the OHT model in general, but also in conversations around improvement and performance improvement. So I think we definitely are looking toward what training would look like. I think with our RISE colleagues and others, and I know that that Ontario Health, you know, in moving forward and working on guidance and what supports are needed for teams to be developing quality improvement plans, I think that needs to be on their radar as well. So thank you for the questions.
Great. And Walter, this question is for you from James Chan, who asks, thank you for an excellent presentation. If this question has not already been addressed or asked in the chat, can you please comment on if or how this measurement approach will be able to make causal claims about the impact of the OHTs compared to the treatment people received before or without the OHT work?
Okay, so without taking everybody down a long statistical highway, to the extent that we can, we will work to identify individuals who are actually being enrolled in OHTs. So I think at a very macro level, it would be pretty disingenuous for us to say that for each of the OHTs in the first year, we're going to measure something on the entire attributed population and say whether you made a difference on that compared to the OHTs or compared to similar populations that haven't implemented OHTs. If we could say, get down to a more refined level of saying you targeted frail seniors, and in your frail seniors population, we see that you were able to achieve lower emergency department visits and lower fall-related visits and lower readmissions to hospital as compared to other similar regions and patients in other similar regions that had not implemented a seniors targeted program, then we could do that. Our ability to do that will range a little bit. We would, if possible, use what we call propensity matched comparator groups, and you can look back on prior evaluations that our network has done in HealthLinks and in the integrated funding model programs. Otherwise, we'll be looking at time series, which is another quasi-experimental design. So really different types of statistical quasi-experimental designs we have in mind. That said, in early days, we expect it's going to take time to start to see these metrics move. And we're very cognizant of that. And so if we can see that teams are building trusting relationships, are moving together, are able to enroll populations and measure some things like patient experience, those are already advances on where we stand today in most cases. And I would call that success at the outset. I'm going to pick up one question here I see out of the chat, Bernadette Kobilodo, wondering about a centralized measurement strategy. So I just want to be a little bit, what are we doing here? We will return all of our indicators to each OHT. And so you will each receive indicators, the full set that we've talked about today, based on administrative data from our team within the next 3 to 4 months. And then that data will also be made public. But we'll provide you with tailored individual OHT reports so that you can see in your own OHT how things are going. That's the short run. The medium run is to think about, are there specific requests that OHTs have around data? And we're working in collaboration with a number of groups that are being supported by the Ministry of Health in supporting the evaluation of OHTs, including ICES, including the Primary Care Research Group and RISE. There's also frontline support from health coaches to help with population health management that will be out there. And those are kind of medium run solutions to help OHTs advance, and also to use some of other data sources in a more specific and responsive approach, as opposed to this generic approach that we will undertake. And then there's the long run question of how do we enable population health management and data reporting at a macro capacity across Ontario. And I challenge Ontario Health to take that on in a massive way. That's just my frank opinion, being a group that will both have capacity and a mandate, I think, to do so. So back to you, Bernadette. Jen.
Yes, so lots of questions and comments especially coming in, which is fantastic that we've got a great dialogue amongst our participants. So I have a question here from Alim Banji, who asks, not part of an OHT, but I'm curious to understand how the OHTs are capturing the data framework that was presented to be a learning system. What platform or tools are being leveraged across the continuum of care that engage providers as well as patients and families and caregivers? Do these platforms show real-time progress, or is this still manual at the moment?
I turn that one back to the chat. You have to tell us. We're still learning. There might be 1 or 2 examples of where we're seeing that, but we are very much in the early learning days. I don't know, Jillian, do you have any insights of teams that you've seen working in that space?
So leveraging a data platform?
Yes, I think that was the core of the question, was having a data platform where they're using it to share data across themselves and measure performance and feed that back to their providers.
Yeah, so many teams are leveraging a ministry tool called IntelliHealth, and that is an online tool that you sign up for, and data can be captured by provider, and other teams are using integrated data systems. I'm not saying that right, IDS. There is a cost associated with that platform, but my understanding is that all teams, all providers involved would input their data, and that there are tools and resources in that platform to help with an understanding of what the performance is looking like across the team. So yeah, there are definitely tools and resources out there at varying levels, and we are working to better understand what is available, and also, you know, for instance, within telehealth, how can we be better supporting that tool for teams to better utilize their information by team versus, you know, having to select which providers are involved, for instance.
Okay, Jen, can we take one more just before we close off here?
Absolutely. So our last question will be coming from Megan Perrin, who asks, how will the Ministry of Health leverage the newly released Ontario Health Equity, Inclusion, Diversity, and Anti-Racism Framework, and how it can translate to OHTs?
Yeah, so this is something that we have done some thinking on for sure. You know, I think obviously the vision for OHTs is it's a population health model, and we want to ensure that in the development of teams, that, you know, the populations with which they serve, they're considering, you know, all of the varying communities that exist within, and so we're working with a number of our colleagues as well as stakeholders to understand what is needed by teams, you know, from an engagement perspective, an appropriate, meaningful engagement perspective, but also from a tools and resources perspective. You know, at the end of the day, there's a vision for what an Ontario Health team is, but how it is constructed and what is included, who is included, from a provider perspective, is really up to the team, up to the province, up to the providers involved, and we're here to support that. And you know, so you know, obviously diversity and inclusion is paramount to the success of the model, and we're trying to understand, I think, a little bit more, as well as Walter mentioned, how kind of we're measuring the success of that. You know, obviously it's expected that teams are considering the entirety of their populations, but you know, as we know, there are gaps in data and an understanding of that from a reporting perspective, from a measurement perspective. So I think just based on the conversations that were happening earlier and the work that's being done to advance the data will only help to support how, at the end of the day, we're able to say we've done a good job at this or not. I don't know if you wanted to add anything to that, Walter.
No, I think that's really great. Thanks, Jillian. We need to learn a lot about how do we really think about and report on, and we can only know where we shine the light. And so we need to find many, many more lights because we don't have enough now. It's a little bit dim out there, frankly. We're going to come around to closing off now. And I have one very last quick poll here before we close out. And how much of today's information will you use to inform measurement in your OHT? And I'll launch this super quick, and we'll take it down fairly quick. So please be in as quickly as you can. Quite a bit, some a little, nothing at all. How useful did you find this? I'll say that we hit our absolute maximum. So you may actually have colleagues today who didn't get into this webinar. It's the second time this has happened to us. It happened the first time we launched one when we only let 100 people in. And then we immediately expanded. And now it happened at 500 people a year later. So it just goes to see how quickly the movement and the energy for Ontario Health teams is advancing across Ontario. And I really give credit to everybody joining in the call today. And so thankful that you are all participating and really learning here and participating along the way. Okay, so sharing out the results, actually quite a bit, 50% and some 43%. So I think we were mostly useful, except to one poor soul who suffered through an hour and a half of this, even without finding it very useful. So I just want to say thanks to everyone. We will be posting this online and the slides. We aim for the end of the week. At worst, it'll be starting next week. And we're here every Thursday, every fourth Tuesday of the month. from 12 to 1:30. Put that in your calendars. Recent ones were on measures for local evaluation and evaluation measures today we talked about. Next month, stay tuned. We have some really, really interesting work coming out on population health management. Our team has been working to understand population health management and help give you an understanding, talk about segmentation in populations, and finally, we have some excellent information coming from case studies around the world where they have advanced population health management. So keep that up. Fourth Tuesday of the month, every month. We are backed by a great team today. You saw Jen with questions. Nusrat's running the entire back end here today. Shannon, Kaylee, and Gaia also online. And Luke over there in the corner gets to do all of the work that we said today around calculating and reporting out on the measures. So we support you with all of our team. Some other resources are available from the ministry and our website. And just keep in mind that all of us, everyone's involved. You can follow us and see our website online. Thank you very much for joining us today. Have a wonderful afternoon, and we'll see you again next month.